Well, next up we have Dr. Kim. She is I'll let her introduce herself, but she's a liver and pancreas surgeon here at the Huntsman, and she'll be talking about surgery for liver metastases, the importance of multidisciplinary care. And I think she's going to bring together a lot of the topics that we've just talked about and set us up well for the case discussions. So let me turn it over to her.
Great, thank you so much. Is my video on?
Your video's not, your microphone is.
Here we go. How's this?
Very good.
So as Dr. Huang mentioned, my name is Rebecca Kim, and I'm one of the hepatobiliary pancreas surgeons here. Hopefully, this is the great thing about going at the end is everything has already been mentioned. So I think I will just kind of emphasize and highlight things that are important and hopefully bring it all together and really stress the importance of multidisciplinary care in taking care of these patients with metastatic disease to the liver. So in the next 15 minutes or so, I'll highlight some practical considerations when it comes to liver surgery. I'll touch upon the hepatotoxicities that Dr. Solomon had mentioned that are associated with systemic therapy, and then review one of the randomized controlled trial, the earlier ones, on perioperative chemotherapy, and then hopefully provide a roadmap for coordinating this multidisciplinary care that is so key. So 16th century French physician Ambrose Paré, regarded by some as the father of modern surgery, is quoted as saying, "When the liver is wounded, much blood cometh out." Fortunately, great strides have been made in liver surgery since his time, and in fact, since the mid-1950s or so, there's been dramatic improvement in our understanding of liver anatomy and physiology, which have permitted surgeons to break open the liver capsule and start removing tumors that were once considered inoperable. Biomedical devices have improved imaging and surgical technique, allowing us to operate without the terrifying blood loss experienced by Dr. Paré's contemporaries. And as previously mentioned by other speakers, this is pertinent tonight because 1/4 of patients with colorectal cancer will present with synchronous hepatic metastases, and almost half will eventually develop metachronous liver disease. And of course, left untreated, I think as Dr. Schiesman mentioned, patient survival is poor. But fortunately, with a combination of surgery and systemic therapy, 5-year survival rates are approaching 50 to 60% in most of our current series. So from a practical standpoint, when we are looking at liver surgery, there are kind of 3 main factors that we really consider: patient selection, tumor biology, and technical resectability. Patient selection, just as Dr. Schiesman mentioned, the same holds true for surgery. Major liver operations induce great cardiovascular stress for the patient and for everyone else in the room, as we usually require low central venous pressure anesthesia during the parenchymal transection in order to reduce blood loss. So patients really need to be relatively fit and have well-controlled comorbidities. Second, as mentioned by everyone else, tumor biology. So we know patients who come for metastectomies, they already have the microscopic and the macroscopic metastatic disease. Thus, it's really important to evaluate for the extrahepatic disease and also assess the response to systemic therapy while the tumor is in situ. And, of course, I am biased because as a pancreas surgeon, I'm all about the neoadjuvant. And so that is kind of a holdover for me. But once both of these factors are deemed favorable, We look at the technical aspects of resectability. And essentially, I think as Dr. Solomon had mentioned, the question is, what is the relationship of the tumor or tumors to the hepatic vasculature and the biliary anatomy? And now the ultimate goal of surgery is to obtain margin negative resection of all gross disease with the preservation of adequate vascular inflow and outflow and biliary drainage while ensuring sufficient liver function. Unfortunately, it's that last point, that ensuring the adequate functional liver, that's really the Achilles heel for liver surgery, as we have yet to really identify a good marker or scoring system that helps us to accurately predict postoperative liver failure. As has been mentioned, many liver surgeons accept 25 to 30% of the total liver volume, minus the tumors, as the cutoff value for future liver remnant in a normal liver, while 40% is typically used for a cirrhotic liver. But it's kind of unclear what volumes are going to be necessary following extensive courses of chemotherapy or chemotherapy in the setting of fatty liver disease and metabolic syndrome. So I think, yes, this has already been mentioned, but this was a study coming out of MD Anderson. Basically, it was a retrospective cohort study looking at 92 patients with metastatic colorectal cancer to the liver who underwent hepatectomy and a detailed pathologic analysis. 75 of the patients had systemic chemotherapy, 17 did not. And the chemotherapy in this study was 5-FU base for 25 patients and 5-FU plus oxaliplatin for 50 patients. Clinical and operative factors were similar between the two groups. However, vascular abnormalities, specifically sinusoidal vasodilation, congestion, hemorrhagic central lobular necrosis, and nodular regenerative hyperplasia were more frequent in patients who underwent systemic therapy. Meanwhile, the incidence of steatosis was similar between the two. And then interestingly, chemotherapy was associated with increased intraoperative transfusion, 1.9 units of blood versus half. And additionally, the presence of most severe forms of vascular alterations were closely associated with that transfusion requirement. And lastly, receipt of more than 12 courses of chemotherapy increased the risk of reoperation from 0 to 11% and increased the length of stay. This second study, also from MD Anderson, confirmed that oxaliplatin, again, was associated with sinusoidal dilation. Irinotecan was associated with steatohepatitis, and as was presented by Dr. Solomon, patients with the steatohepatitis had a 10-fold increase in 90-day mortality. I do want to note that the median duration of chemotherapy in this study was 16 weeks, so 8 cycles. And then, so from these studies, and as has been mentioned, it is clear that longer duration of systemic therapy, while great for downstaging the tumor, has negative impact on liver function and subsequently impacts surgery. So I just wanted to show here a couple images of the liver. So this lower one shows the characteristic blue liver that's associated with the oxaliplatin sinusoidal injury. And then the top right photo shows a yellow liver associated with the steatohepatitis. Again, so there are 2 published studies from one RCT that I wanted to discuss regarding perioperative adjuvant therapy. The first is the Epoch Trial, or EPOC trial. It was published in 2008. So in this trial, 364 patients were enrolled from 78 hospitals, mainly in Europe, between October 2000 and July 2004. Patients must have had no more than 4 potentially resectable liver mets and no detectable extrahepatic tumor. And then the patients were randomized to surgery alone or perioperative FOLFOX. So 6 cycles before surgery, followed by 6 cycles after surgery. Treatment started 3 weeks after randomization, and liver resection was done 2 to 5 weeks after the last administration of perioperative chemotherapy, once the patient had recovered from that chemo. And as mentioned previously, the primary endpoint was progression-free survival. And as you can see here, perioperative chemotherapy with the FOLFOX reduced the risk of progression-free survival at 3 years by about 25% in patients with resected disease. That's the green line on the Kaplan-Meier curve here. Note that the rates of resection were about the same between the 2 groups at 83 to 84%. And then the second study is a longer term study of the previous with a median follow-up of 8.5 years compared to 4.8. And again, there's no difference in overall survival. However, the progression-free survival was 75% higher in the surgery plus chemotherapy. So from a surgical perspective, my take-home point was that, okay, so 6 cycles of FOLFOX really did not increase the rates of hepatic, did not decrease the rates of hepatic resection, nor increase the post-op complications. So I kind of wanted to take a step back now and talk about some of the protocols that other institutions have been using that are currently published. So MD Anderson, so patients with resectable colorectal liver mets at MD Anderson typically undergo 4 cycles of perioperative FOLFOX plus bevacizumab, based on presumably the Become trial. And this is followed by liver resection, and then post-operative FOLFOX without bevacizumab is then given for 8 weeks to complete the 12 cycles of systemic therapy. And then in this paper, they noted that for borderline or unresectable colorectal liver mets, FOLFOXIRI plus bevacizumab is given with the goal of converting to resectable disease. Again, kind of based off of the Olivia trial that Dr. Solomon had mentioned. This is another schema out of Zurich, Switzerland. And patients here, I actually really like the way they categorize this. And there's one last schema that I'll show that's somewhat similar. So patients are categorized based on resectability. So for example, if you look at this resectability column, resectable by 1 stage with future liver remnant greater than 30%, this algorithm then goes to resection plus or minus ablation or ablation alone. Resectability by 1 stage where your future liver remnant is less than 30%, pre-treatment portal vein embolization, and then monitoring to see if you have sufficient hypertrophy. If you do, then you go to resection. If you don't, then 2-stage hepatectomy versus ALPS, where ALPS stands for the associating liver partition and portal vein ligation. That's the surgical procedure where the liver parenchyma is divided, the portal vein is ligated. The patient is kept in the hospital, usually for about a week or 2. CT scan confirms hypertrophy, and then the completion hepatectomy is performed all during the same hospitalization. So, if you've got insufficient future liver remnant after your portal vein embolization, their algorithm is to go to a 2-stage. And then as you can see here, you've got resectable by 2-stage, which then prompts neoadjuvant therapy, hopefully downsized, and then your resection. And then for unresectable, conversion chemotherapy, and then depending on the response, either resection or best supportive care. This diagram, I think, nicely illustrates the various categories of resectability that's discussed on that previous slide. This first row here shows what would essentially be a one-stage parenchymal sparing procedure where peripheral lesions are wedged out and then deeper lesions are ablated. The second row shows a solitary mass in the right lobe that would likely require an extended right hepatectomy. So in this case, portal vein embolization is performed with the goal of hypertrophying the left lobe of the liver before going to resection. And then lastly, this bilobar, essentially unresectable disease, you know, one stage, or excuse me, a two-stage or an ALPS procedure can be attempted, where essentially the left lobe here in figure G is cleared out of lesions. The portal vein is either embolized or ligated in order to induce that remnant. Sorry, I'm losing my headphones. And then the completion hepatectomy is performed later. So as one can imagine, these treatment sequencing requires extensive coordination among medical oncologists, interventional radiologists, and surgery, colorectal and liver, and in cases of lung metastases, the thoracic surgeons. So in order to ensure that the sequence is followed in a timely manner to minimize time off of systemic therapy, this really needs to be coordinated in a multidisciplinary fashion. I wanted to just end with this last algorithm that's put out by my mentor at Stanford, Brendan Visser, which essentially uses, again, the similar paradigm that's used for pancreas cancer, where metastatic colorectal cancer is classified into resectable, borderline resectable, or unresectable disease. Now, Jiga had mentioned this terminology, but essentially for borderline resectable disease, systemic chemotherapy is used upfront with the goal of converting it to a resectable disease, and close surveillance is necessary to limit the hepatotoxicity of the chemotherapy. In this particular algorithm, they don't actually specify our duration, but presumably every 4 cycles or so, radiographic assessment should be performed. And if there is adequate response to therapy, but insufficient future liver remnant, this category here, then strategies for contralateral hypertrophy should be considered. And in here, again, as has been mentioned, PVE and Y90 are, I think, excellent options. The benefit of the PVE is it's a faster hypertrophy, but the benefit of Y90 is you're still treating the lesions. So, oops. Anyway, for the sake of time, I'd like to end my portion by highlighting all of you, who I think almost everybody on this list is on the call too. So anyway, thank you all, and I apologize if I've left anyone off the list. There are a whole bunch of researchers who I have not put on here, but are constantly in my mind. So, and at the end of the day, I know that I would not be here if it were not for my patients. And I think I speak for everyone else and our patients' families. They really do inspire us every day and give us hope for new discoveries in the diagnosis and treatment of metastatic colon cancer.